And just like that, we are hitting the ground running with season 2 of GaitKeepers Journal Club. Probably the number one journal club in the world, probably, because who's going to keep track of those stats? So we're going for it. Number one, joined by co-host Brad Abicht. I'm Jeff Dikis. We are joined by a very special guest tonight, Patrick Burns, my residency director, formerly of the University of Pittsburgh Medical Center, now of West Virginia University. How are you boys doing tonight?
Very good. Thanks, Jeff.
Excellent.
Pat, why don't you take a quick minute and introduce yourself to those who don't know who you are, although most people probably do, but then kind of spend an extra minute talking about your residency program that you guys are getting up off the ground there.
Yeah. Well, listen, it's certainly a pleasure to be with you guys tonight. Yeah. So I'm Patrick Burns. For those who haven't had a chance to meet me, I've been in practice for about 24 years now. I spent most of my life at the University of Pittsburgh, about 20 years or so. And about 3 years ago, I started a new program at West Virginia University, which is kind of just a little south of Pittsburgh for those of you who don't know geography, because I really didn't either. I moved jobs, but didn't have to move houses, which is kind of crazy. So I started a new program. I think, Jeff, we had you in Pittsburgh. I graduated over 100 residents and fellows from that program. A lot of really great guys like yourself. Had the opportunity to kind of start a new program at a new facility that's really kind of excited about growing, and in particular growing in our, field. So they really are looking at, limb salvage and trying to help their state quite a bit. So kind of came to me looking to start a program. So we started it. We have our PGY1s who are, 6 or so months into it. We have a fellowship as well. We just did interviews, so just out in Chicago, seeing everybody. It was a great time to be out there. Great group of students. Looking forward to matching for some new PGY1s and, kind of keep this thing moving. I just feel very lucky that I've had a great life and education, really being a sort of friend to people like yourself, Jeff. Just friendships forever, and looking forward to kind of doing that, again, as we build this West Virginia program.
Yeah, I can't recommend it enough. You kind of transplanted some of the people from Pittsburgh and stole them and kind of started a new program from scratch down there. So I'm excited to see that take off and get going. So, Brad, how are you doing tonight? Is it as cold as in Wisconsin as it is in Iowa right now?
Probably even colder, man. I was in the Caribbean last week and it was 80 and sunny. Came back to Minneapolis and it was -6 when I flew in. So, just trying to stay warm down here, and but hopefully we'll heat it up tonight. With some good discussion.
Absolutely. So let's jump it off, Brad. Why don't you introduce the article that we're going to be talking about? And then I do have a PowerPoint that we can go through the cases and everyone can kind of look at the x-rays together, just in case people did not get a chance to look at the article. Don't worry about that. We'll take you through it. Take it away, Brad.
Yeah. So this article chosen tonight was co-authored by Dr. Burns. This was published in Fast Track, which I'm obviously biased because I'm associate editor, but I think this is a great example of why Fast Track's a great journal, because it allows for publications like this where you can really learn from even these case series type studies and kind of these one-off type studies where they're just not that common, or we just don't have a ton of research yet. So this one was entitled "Complicated Problems Solved with the Use of 3D Printing," which was a case series published last year in 2025. Basically, pretty simple approach, but it involved 5 different cases, which we'll go through, that involve 3D printed prosthetics to treat a number of different complex deformities. Yeah, so I think Jeff, you have a PowerPoint of each kind of case, and we'll probably go through that. But Dr. Burns, I mean, what got you interested in this topic, and how much are you using 3D printing at this point in your practice?
Well, as you said, this is one of these things that's evolving. And I think, maybe 10 years or so ago, I remember actually one of our other residents, and Jeff Dikis knows Pete Highlander. He was kind of getting into it a little bit. And at one of at a conference we were at, he showed some cases. And I remember saying to him, I don't want to learn something new. Like, I'm good with what I'm doing, and I'm not going to do those things. And then you fast forward some years, and I've done many. I think it's one of these things of you're in education, so you're always looking for what can we do a little different or new. I think we talked before maybe about sort of some of the dangers of what's called disruptive devices in medicine, where we do something pretty well and then we change it and spend a lot of money for maybe no good reason. We have a lot of that that goes on, but I think this is one part of what we do that really has quite a utility, quite honestly. So I mean, there is a little bit of a cost to it, but I think for us, whenever you look at the um, difficult anatomy we have, right, the difficult shapes that we have, and missing pieces, and I think it started to make sense to me. So yeah, I started doing some of these things and realizing that, boy, it does have a utility. I think like anything, you have to be a little careful that you don't kind of overuse it. I do think that seeing this evolve over the last 10 or so years, it's I see some good things happening as far as maybe not needing such specific implants as far as like the patient specific. But I mean, it really does help us solve some difficult problems, in particular, around the talus, around the ankle, but also some of the first MPJ problems that we have, medial column problems. Really is quite useful. Yeah, I've been using it quite a bit over the years now.
You think most of the time you're using it in exchange or instead of a dead piece of bone? I'm thinking of like a femoral head allograft for a TTC, or Evans graft, or a midfoot wedge graft for a failed lapidus that's too short. All these situations where we would maybe put in a structural dead bone allograft and hope that it magically reincarnates, comes back to life, and then heals. Are you finding that's the case, or does it vary?
It is definitely a case for sure. I think that, I haven't used a femoral head in I don't know how many years now. I think you're 100% right. You're taking this dead space. We know that what's called sort of bulk allografts, so anything over 2 centimeters, we know from like our orthopedic oncology colleagues, anything more than that, I mean, it's not going to heal. We know previous substitution will never get into these huge bulk allografts. And so, certainly like others, and I even published on some femoral heads in the past because that's what we had available, right? So you either did a tib calc fusion or you put a femoral head. And, after having some failures of those, um, this definitely gives a great option for that. And what I've found is with some of the large spaces like you're talking about, even putting in some of these allografts is definitely non-healing, fracturing of, losing some of the correction as it sort of heals, and you just don't obviously get that really with metal. It's not going to change, um, you know, width or height or anything. So I've been so much happier, and I can tell you just from my own experience as well. I think the other thing is it's hard sometimes to fixate some of these bulk allografts, and I think with that comes a little bit of movement, a little bit of swelling, a little bit of this, and you just see this foot in your office of this big, huge, swollen foot. And these sort of patient specific implants are so friction heavy that are made to kind of stick and grind and hold. And I don't see the amount of inflammation. I don't see the inflammatory process. I don't see this big, swollen, huge thing. And they're just so much more rigid from the start. And they don't really lose that rigidity. Like I said, you would get sometimes with the allograft. So I think it's a great, great uses whenever you have some bulk allograft. It's a great use for it. Yeah.
Real quick,
Can you?
before we get into the nitty-gritty of the article, sorry, Brad, I
You're
wanna
right.
take it back to the studs for a minute. Take it back to the basics. Let's say you have a patient, you're sitting in your office, and you think, "This would be a great case for a 3D printed whatever." What can you walk people through quickly what that process looks like? CT scan, contacting a company, sending the CT scan, are they sending multiple options in different sizes, or does it depend on what you're asking for? Do you have to pick the material? Do they give recommendations? Let's say someone has never done this before. Can you give us a few basics of what that process looks like?
Yeah, that's a great thing, because certainly the first time you do it, like, oh, geez, I didn't realize that was going to be kind of like that. So I would say that working. I know the first time that I was getting into these things, I thought to myself, working in a big institution who's really worried about sort of HIPAA compliance. That's actually number one thought that I came up with is I have a disc. I'm going to hand it off to a rep or a company that has patient information. So I can say that in private practice or certain practices, you may not have that much of an issue, but I can tell you at a major university, that was a complete no-no. So the first thing we had to do was get the companies vetted, where they had to prove that they have the ability to protect this patient information because you're giving them the disc.
Mhm.
So that's the first thing. Now they've made it easier where you actually can upload it yourself. Now there's no longer I give a disc to somebody and it has to go into the mail or something. Now you actually can get on the website, upload it yourself. So it makes that much quicker. So the next part is, like you said, you're right. So you have a CT scan that then is uploaded, and then you typically have some discussion with an engineer about what are you looking to do here, so they can build this 3D model, and they know, okay, I'm missing this piece. What they normally do is they take and they say, okay, well, we know the foot's supposed to be here, we know the big toe is supposed to be here, so they have some ideas, so they can manipulate the CT to what they think is normal. And now they take that space and they say, okay, well, this is what we have to fill. So you do have to make a call and have a like something like this for your FaceTime or something with engineers. If you want to place screws, you talk to them about, well, I'd like to put a screw from here to here. They'll tell you if you can or can't. They'll tell you what size. I want to put a 6.5. They might say you can't because that's going to take too much implant. So yes, there's a discussion with the engineers. And then, yes, you're 100% right. Then they typically come up with, a plan. Okay, this is what we think. This is the size we think. And then you make a decision. Okay, well, I would like one maybe a little smaller because maybe I get into surgery and it's kind of not working and it's smaller, or we make it a little bit bigger. So they might make 3 implants for you, what they think is normal, and then smaller or bigger. Or you can do other things like sometimes it's, I want this normal and then make a bigger and then an even bigger. So those are discussions you have with them. But I would tell you that generally speaking, by the time you have that sense, you discuss with engineers and they have to make it. If it's 6 weeks, you're lucky. It's more like 2 months. And so that gets back into this. What do you do with your patient for the next 2 months while you're waiting for, this thing to be made?
Go ahead,
Yeah,
Brad.
so you kind of mentioned this in your article, but as far as the materials that these things are made out of, common materials might include the titanium alloy, or if you're trying to put a articulating surface on one of the implants, that's likely going to be cobalt. I don't know if there's other materials that you've also used. Some people out there are using PEC. We've talked a lot about PEC in some other events that we've done. Um, can you talk just a little bit about, yeah, do you get to choose those materials? Are those suggested to you by the engineer, or is it depend on the situation?
It's a little bit of all those things, but I would say that generally, from my discussions with engineers, from an FDA standpoint, the only thing that can be polished for a joint is cobalt chrome. So if you are just doing a filler and you're, just doing this, it can be titanium, it can be some other materials, but if you want like doing something that I want to tailor navicular, or if you want a joint surface, the polish can only be done on cobalt chrome. So that sometimes will change, what you're having the implant made out of.
Go ahead and jump into these cases here because I think this will be the most interesting way for people to absorb this information is get some real life situations. So the first case, a 51-year-old female with AVN of the talus, status post open extrusion motor vehicle accident. So why don't we talk through people that are here and people that may be just listening in future podcast recordings of what we're looking at here on these x-rays?
Well, yeah. So I think this is someone that was sent by one of the trauma partners, and I think this is where I've seen a pretty good utility for this. Where we end up sometimes with some talus pathology because it's such a difficult bone, right? So either having an extrusion, or even like tailor neck body. I've had a few where the patient's so sick or having such a that they can't get to the ORIF. And quite honestly, sometimes I'm happier with them not doing it, because you have incisions then that you don't want, and so sometimes just leaving it, and then in a short amount of time, then I can get this talus out and maybe put just a real talus in there. So this is someone, you can see the sclerotic tailor body here. Obviously they kind of did a large cannulated for the fibular fracture as part of the extrusion. But this is one, after talking to them, I said, just leave it. She had some other health issues going on, and then I can come back and put a total talus. Now, the issue with that then gets to be, if you have a fractured talus, a tailor neck body, um, what kind of damage is that causing while your implant is being made? And that's what I said, that's one of the problems about patient specific, is there is a little bit of a time gap there, where do you want somebody walking on something that's grinding, rubbing, scratching for 2 months before you put a total talus? So you have to kind of figure out how you're going to mitigate that, whether they're non-weight bearing, whether they're sometimes in a fixator and you just leave it for a while. Because if you get a CT scan right now, like we did, by the time they make an implant, it might be 2-3 months later. Is there anything different? That's the kind of question here. But if you can get to them kind of quick enough, then we can just, take it. So it goes back to what you said before. Would I rather have this big dead piece of talus, or would I rather have, maybe something that is articular, may or may not, kind of crushed down depending on what happens with this avascular necrosis. So this is somebody that we just said, leave the talus alone and we'll replace it whenever she's healthier.
Is that kind of your thought process? Like if you were debating between this approach versus a TTC fusion, which is a kind of traditional way, I guess, for treating AVN of the talus, maybe not in the acute setting, but in a chronic setting. What was your thought process there about, yeah, considering a TTC fusion versus, I guess, a total talus?
Well, I think, yes, that's obviously our sort of was always our go-to, but I think like Jeff said before, I think with somebody that has this much sclerosis, you have, it's basically the entire body. So you end up with, is the talus going to heal? Probably not. So are you going to take it out and put in a piece of femoral head? Well, that's no better than what you have right now. Or are you going to do a tib calcaneal? And, someone who's 50 something, we all know, if you have someone who's otherwise normal, that can be a little bit debilitating. We do it a lot for other patients, and it's for limb salvage or something. But for someone, you want to try to maybe have, some semblance of normal, and, have, some weight bearing, some ability to get around. And quite honestly, for a surgery that takes maybe uh, 40 minutes if you're slow, it's unbelievably quick. You think it's going to be difficult, but it really is quite quick, because once the talus is popped in here, you're done. Um, I don't do holes for ligaments. These things are so stiff as they are, the way they are, that I don't see the need to waste my time on putting. You'll see some people put little holes for ATF, or little holes for deltoid, or little hole. I find that's completely useless. Quite honestly, I think it's a waste of time, and you're just gonna, you know, drive yourself crazy. These things are stiff, right? So it's not going to go anywhere. But I think for certain patient populations, a TTC can be, a little bit more debilitating. Um, and any other option is, this is dead. The femoral head's dead. So maybe putting an implant that has articular surface, I think, makes sense for someone like this.
What's your technique for getting that talus out? What's your first cut? What's your next cut? What are you doing to get that talus out?
Yeah, believe it or not, it can be pretty simple, because obviously the talus doesn't really have a lot of attachments, right? So if you anterior approach, right? So you kind of tib band EHL, get out and you make a cut, and you of the tailor neck, and then you can pop the head out pretty easily. So that you kind of tailor neck, pop the head out. Now you have access to the body. Most of the time, like one or two kind of cuts in the body, and I'll just kind of cut the body into kind of some quadrants and some pieces, and pull them out. Obviously, just kind of have to be careful. Remembering some tailor joint, you don't want to put a saw through the posterior facet of, the calcaneal component of that. But you can take a saw and kind of, break it up into a couple pieces, but it really comes out quite quickly. And that's it. And then you start popping in some trials, and then you pop in the real one, and that's it. Now you're zipping it closed, and you're done.
think in this case, you mentioned this patient also had a Bowman gastroc recession. How often are you having to do that with these total talus?
I mean, I would say probably just about everybody gets that because probably just about everybody's tight, whether they were tight before they had your injury or now they're tight because they've been in a cast or they've been in a fixator, for a little bit of time. So I have a pretty low threshold. I don't think it generally causes trouble. I think gastroc itself is a pretty um, stable lengthening versus T. I'm not a TAL fan at all. I think that should be kind of outlawed, but gastrocs are very stable. And it's a good way to get just a little bit extra movement.
How do you get this in there? So we talked about how to take it out. You make a tailor neck cut and you pull the head. Can't really do that with this in reverse. So now we have this space that's confined. Are you
Yeah,
plantar flexing maximally and pushing A to P, or what's your first maneuver to get that in there?
it is. It's kind of getting the body in, and then you plantar flex, and usually kind of in sort of plantar flex and sort of like adduct the foot, and it kind of pops in. But that's how you do. You get the body in there. You pull the foot down, plantar flexed, and kind of pull that foot into adduction there, so it pops the TN joint in there. It actually is really not too difficult, and you get a good handle on it literally because typically the trials have a handle, so that you get a kind of a good idea of how that pops in there for whenever you have the actual. There are some people who make a handle for their total talus. I have not done that myself. The trials do. Um, So the trials tend to kind of look a little bit like this, where there's kind of a handle, and then you kind of pop the body, and then you pull the foot down and pop it in. So some people will make a handle that screws into the tailor neck area to kind of help push down. I haven't needed to, but
And might it be indicated to include a stem that goes into the calc or a screw or something that might make it a little more stable? Like I noticed this one doesn't have it. I've seen
yeah.
some others that do.
Yeah, you'll see some that do. So because this is more sort of acute, kind of AVN from extrusion or some of the tailor neck body problems that I've had that had no other surgeries, your subtalar joint's probably okay, right? So it's not, we don't have a lot of, post traumatic yet, and we don't have pathology that's really affecting subtalar joint. So if I have that, then I will just put in an actual just talus. If I have other issues, that has with your CT scan or something, you see that there's subtalar joint changes or problems, and so for some of the total talus, total ankles, that's a little bit more common, and then that's what we call kind of constrained. So I think we probably have one or two of those here. So you kind of include the subtalar joint as a fusion kind of part. So that would be then termed a constrained total talus, where it's kind of stuck. So I only do that if I have like actual subtalar pathology, though.
Let's jump ahead to this 49-year-old male, history of total ankle arthroplasty with some subsidence and failure. And the talus is a common theme. The talus is just a piece of shit bone, I guess, because we seem to be trying to take out the bad and put in the new and replace it. And all the bad things seem to be talus related. But what are your thoughts when you see that x ray come in and they have that failed total ankle?
Well, I think like everybody, you're immediately. I mean, you think about the first things, but I'm already thinking like step 4 or 5, and what am I going to end up with? So, like you said, is any of this talus useful? Um, if I can keep a neck and head, I will. Just kind of depends on the pathology going on. So for someone like this, I might say, okay, well, I can keep maybe the head and neck part of this because the subsidence was all body. You obviously got to rule out infection problems and issues like that, which this guy kind of actually had, which is why he's got the fixator with the cement arthroplasty. But I think, like you said, this 3D or patient, it has really, really, really given us such a better way to handle talus problems because, obviously one of the problems with total ankles was, infection problems or this kind of problem. And then what do you really do with it? And you're sort of stuck. So boy, it gives us really a very useful way to salvage these problems.
believe
And
this
this
one
would
was
be one
converted
that, you
to
know, you have a subtalar that's probably going to be involved. So you got to think about like how you're going to include that in on your construct.
like this one you converted to kind of the Death Star approach. It looked like.
Yeah.
What can you talk a little bit about? What do you fill the Death Star with? Any certain type of, is it autograft, allograft? What kind of biologics are you using to try and, just get any of this to incorporate and heal?
Yeah, so certainly there's some, allografts that I'll use, but usually for these, because I'm doing some sort of intramedullary technique, I usually will keep not just the simple reamings, but actually another thing I learned from Pete Highlander. So I typically will kind of almost use like a RIA, the sort of rear, reamer, irrigator, aspirator kind of idea where, you pass the reamer up, you come out, and then I can pass along that guide, that ball tip guide wire. I can take some of the suction tubing and you pass it up through, and and then it has a little container. So you pass that, you push it all the way, and I ream all the way up to the tibial plateau every time with my nails. So I push that up, then I ream to a 10, then I push that all the way up, and then I ream to a 10, and then I put in that. Then every time I kind of push that suction up there, I'm collecting that into a little container, and then that's just a nice patty of reamings and things that I can use. So that's a pretty useful tool for whenever you're putting an intramedullary device, just to kind of try to keep those reamings.
Did you do a lateral takedown primarily? It's hard to tell on those X-rays.
No.
Or no, you did anterior approach removal and then a lateral takedown to fuse?
Right. And so that goes into this whole thing of thinking of steps, at least for me. So I think that style of implant, to get out, you have to think how you're going to do that. And really, quite honestly, the easiest way is from the front, because that I actually had to make a window because that stemmed implant was, ingrown pretty well. So I actually made a little window up around. So you'll see in the like post ops, you'll see that kind of window, missing, so that I could get that out. So you can almost, maybe you can see on that lateral where the anterior cortex is kind of knocked out. Again, I don't really care because I'm putting a 300 millimeter rod up there. So whether there's a little piece of anterior cortex missing or not. Now that person had a total ankle incision, then I had to go back in and take it out. So when I come back later, I start thinking, do I really want to go through a third time, or do I want to do something different? So I can go lateral. It's a very comfortable place for us. It also gives you the fibula. So when you talk about bone graft, because it was still there, and this ball can be put in from the front or the side, very, very easily. So not a big deal. But it's just, fresh skin that I never had before. Yeah.
So we haven't really talked about, I forgot the article at work. I printed it, I highlighted it, and I left it at work. So I can't check back to it with my PowerPoint up on my other screen. So you're gonna have to help me out. We haven't talked about how these patients have done. How are they handling these implants? Are they generally successful? They have good outcomes? Are they happy? Have you had to revise any? What's your general consensus with the outcomes? Not all, they don't have to all be fantastic, but general consensus.
The general consensus is this has helped me significantly with these patients, really, quite honestly. Now, this is stiff for this guy. He should have never had an implant to begin with. And he then came back for his other side, and I just did a TTC from the start. He was way too big. He had way too many. This guy should have never had a total ankle done, and especially that one. But this makes it so much more reproducible and predictable for me, and I can only think of one person that I've had recently who really failed, and that was somebody that pushing the envelope was like some neuropathic people.
Is
What are
there a
their Go
is
ahead,
there a
Brad.
plan C here? Like if this does fail, I mean, obviously each case might be different, but what if this fell apart? Then what?
Well, I guess it depends a little bit about the patient. It depends a little bit about like what fell apart. Was it like a construct problem, or a fusion problem, or is it an infection problem? Infection problem. It just might be that's it. It's also, I think, for a guy like this who's had a few surgeries, had to fix it on for some. He may be done anyway if something fails. So I think that's obviously always on the list, and that's a sort of unfortunate thing that happens with certain bigger surgeries. Luckily, we do have some ways to salvage like this. I mean, total ankles are very useful, but when you have some trouble with them, um, yeah, you can have some issues. But I think it would just depend a little bit about the patient. If he might say, "Listen, I've had a few surgeries, I'm done," type of thing. But luckily, he did well, and like I said, he came back and we did TTC on his other side.
What are the contraindications for 3D printed implants? Because if these patients were fantastic hosts, then the primary procedure would have been successful and we wouldn't be in the revisional setting, perhaps. So, by nature, considering these are revisional cases for the most part, are there any contraindications? Are there any things that jump out to you as, oh, that's going to fail, or I shouldn't do it in this patient?
Well, I think not all of them are terrible hosts because like I said, that Taylor
Yeah.
extrusion is just an unfortunate person, and
Right.
this guy was uh 300 and I forget whatever, but just a big guy. Like, again, I think it was just poor choice of surgery because he did okay with his TTC on the right side that we did primarily. But you are right. I mean, there definitely are a lot of sort of revision parts to this. So you think, so we need a heel. I think personally replacing the heel is a terrible idea. um, if I don't have a good heel bone, then that's a problem. Uh, I tend to, like this one, I left the neck and head of the talus and just leave that, and I don't try to fixate it. I just kind of leave it. I have not had trouble with that. Some people will try to incorporate, screws into the tailor neck and head, and I just think that, again, you're kind of wasting your time for something that doesn't seem like it's necessary. So I think bone stock, bone quality, what kind of bone do you have? We have to have a heel bone to, support these kind of things. I mean, I would say infection, except for the fact that, yeah, we use it for a lot of infections. And I think, like most things, you're just trying to, you do your antibiotics, you follow your labs, you do your cultures, I do frozen section on a lot of these patients to kind of like, is it ready to put in a metallic implant? But yeah, I mean, a lot of these we're putting in on people who had infections in the past. So you're keeping your fingers crossed that, the one I just had recently that kind of failed. That's the problem. Is he just the whole thing got infected. Um, but that's probably the thing there. I think, yeah, you have to have a patient that understands the process. You have to have, the bone quality around it. Is probably a big one. And skin, I think when you start doing things like first MPJ, I don't know if one of those is in here. That's another one of those that's really tough. We have such difficult skin there, and people have had 4 or 5 surgeries, and all of a sudden you're trying to stretch it out and put an implant in there, and you can get into wound problems. So having good bone, good skin would be important.
So we talked about AVN and infection. Those obviously make a lot of sense. What about Charcot? You said that you need a structurally supportive heel bone. What about hindfoot Charcot? Would that be contraindicated? Putting a lot of stress down onto the calc in a hindfoot Charcot? Or is this just the salvage procedure that we need to do and we know the inherent risks of Charcot bone not being fantastic sometimes?
Well, I think if I have a calcaneus, then that's the most important part there. I don't really, it doesn't really matter as much how much tibia, because I can either I can make my implant taller and taller if I have a lot of tibia that I'm cutting out, or I just make the leg shorter. But those are the kind of patients like, okay, would this be somebody that's better just tib calcaneal, or do I want to try to maintain height? I mean, there's certainly issues about having this short limb. Not that we can't modify that with shoes, but there definitely are times where I'll put these into a Charcot patient for space management, for a little bit of height management. Um, and I haven't had trouble with them except for the one that was infected. But I haven't had to, it kind of come through the calcaneus or anything. So for me, it's been definitely on the list of potential treatments.
Case 3, 29-year-old female, so pretty young, OCD of the Taylor Dome, had 2 surgeries that have kind of not solved. I hesitate to say failed, but have not solved her issue. We're looking at subchondral cysts and some overall degenerative changes within the ankle joint. So, what are your thoughts when you see this in terms of 29-year-old? I know the indications for total ankle are kind of trending downwards somewhat, maybe not all the way to 29, but trending down somewhat. But what are your thoughts on procedure options for this? And then we'll talk about what you ended up doing.
Yeah, these are always our problem too, right? You get like a 30-year-old with a pretty good osteochondral defect, and obviously scoping is kind of the first thing, and whether you do some sort of allograft with that. So, but after a couple surgery, obviously at this point it's kind of like, okay, can you do something like an oats, um, steel cartilage from somewhere else? There are a couple allograft oats available, some fresh kind of uh, allograft plugs. There are a couple other little plugs as well. So there are a couple things on the market to do. But yeah, these are really difficult because it's you're talking about whatever, a quarter of the joint. Do you really want to destroy the entire joint for this thing that's kind of a quarter of the joint? But where are you at after a couple surgeries? That's really the stinker when you scope someone and 3 months later they're like, yeah, this thing still feels exactly the same. And this one's obviously kind of a little bit larger and has a little chunk missing. So it's just, again, there's another there's potential options here, and this is where maybe again another patient specific implant is at least on the table. I
What
mean,
are your
I've done in the
Yeah.
past many times, you know, allograft where I've cut the entire dome of the talus off and replaced it with allograft and things. But I think again this is kind of another option at least out there.
That's what I was going to say. So, what are your thoughts on a fresh talus allograft versus 3D printed? I felt like we did a couple when I was there, and yes, you've CT matched the fresh talus, and it's pretty close, but it's never exactly what you want it to be. Versus the 3D printed should be perfect. Question mark.
Mhm.
What are your thoughts on using the allograft in terms of fitment? I don't know if that's a word. How it fits versus the 3D printed. Yeah, it's a word, Brad. It is now.
Yeah. Yeah, for sure. I think again, I think the allograft, there's definitely maybe possibly a little bit more surgeon, expertise involved there, right? You're kind of like sneaking a saw back there and trying to make a nice, kind of flat cut, and then you're going to try to match that. Whereas with the patient, the one thing about the patient specific is you can get a cut guide. So for pretty much anything that they make for you, you can make cut guides. I'm not a big cut guide person because I can freehand a lot of things, but this is one where I think it makes sense because when they make the implant, they can make it based on this cut, and then that kind of takes my little part of it out, and so they make a little cut guide that fits onto the neck, couple little pins, and then theoretically should be a little better match, like you said.
is this one through an anterior approach as well? The
Yeah, I'm always looking at like, okay, well, uh, you know, when this thing fails, what am I going to do? And converting it to a total. So if you get her, whatever, if you can get her 20 years or 15 years or something, I'm always, I spent a lot of time on orthopedics as a resident and doing hemis as far as knee. We would do a very similar incision because if that thing gets converted to a total knee at some point versus a hemi. So yeah, I kind of try to do the same thing.
makes sense.
So, did you use a cut guide on this one? Like you said, I think that would make it a lot easier. Obviously, doing an anterior approach, you're not doing the fibular takedown because she's young and otherwise healthy. Just for anyone younger listening, a fibular takedown means you're going in and cutting out a huge chunk of the fibula with huge lateral access to the tibiotalo and tibiotalo-calcaneal if you need that. Obviously, you're not going to do that in this case, but do you remember if you use a cut guide or
100%.
um,
Yeah. Yeah. They definitely make a little cut guide that fits onto the tailor neck. Um, and then it has a couple little spots for pins. And then, you're looking at, okay, well, if you're going to put this little guy, how are you going to fixate it? So we just had to make these little plugs. And so they have, the little drill holes, perfectly kind of lined up. And then they typically look like they sit a little bit high because, cartilage, is on there that we can't see on X-ray, right? So they always kind of like look there. There's always this like, it looks like that's not down far enough, but it's in line with like the cartilage, so it's kind of it's not in line with the bone kind of thing. So they sometimes look a little funny, but yes, 100% cut guide on this one. Mhm.
That was exactly my question because, well, you said it already. You're trying to get the implant flush to the surrounding cartilage because that was always the thing with the fresh talus allograft is it going to settle at all over time, or do you want to make it flush? And then if it settles, okay, fine. That's a little bit of settling's okay. But you already answered the question, which is you want this to be flush because you're not anticipating any amount of settling with this.
Yeah. Yeah, right. So it'll always look a little funny on X-rays. So just something to kind of understand how it goes. I guess I don't know, in this article maybe we didn't have the cut guide shown, and or maybe even the intra-op picture of like the kind of level part to it. But yeah, this definitely had a cut guide attached to the neck.
Next
Hey,
case. Go ahead.
Jeff, we got one question. Let's just hit that quick, if you don't mind. And anybody else that has more questions, please feel free to submit that on the right-hand panel in the Q&A section. But Billy Ortiz says, are you using these devices in any primary situations, or are they just being used in these traumatic, revision, and complex cases? I mean, have you ever just gone right to the 3D printing for a primary surgery, I guess?
Well, I guess you're going to see one right now. I would say we, like everything in med, we do have to be judicious and careful, right? So I would not do it for something that I think we have very good, clear outcomes for otherwise. I think, you look at that OCD, couple surgeries in a 27, 30-year-old person. We don't have a lot of great, like, what do you do next? So, okay, it's out there. Or a failed total ankle that's subsiding into the that's a little different, but I wouldn't do it, when we have other, good primary surgeries, because they are expensive, and we do need to kind of be a little conscious about that. Because I've seen people do silly things. Like I literally saw somebody present a case where they had a patient printed sesamoid and they put it in the foot because it's so, like, that makes no, like, who cares? There's no sesamoid. I don't care. So why spend that money? Like, we always do that to ourselves, right? We get a little crazy, and yeah, that kind of stuff. But this case here, this is definitely a primary one, because it's just, again, looking at, like, geez, what other options do we have?
How much do you
Jeff,
think
is
that
that your
sesamoid
case?
cost? Yeah, not me. How much do you think
Well,
that sesamoid cost? Jesus.
well, I'll just tell you. So, like, years ago when we were first doing these things, I made a 3D. I had a 3D thing made, and the bill was like $10,130, something like that. And then my partner Jeff Manway had something made, and the bill was exactly the same. And I remember sending the thing to Jeff, and he's like, "Boy, that's something, the exact same cost for a completely different shape and whatever implant." So I think it was just like, that's what their cost was. Like, this
Yeah.
is what we're going to charge.
Flat,
So he's like,
flat
"That's
fee.
funny. It's the exact same price for a completely different implant." So yeah, yeah,
Hindfoot cage or a sesamoid cost the same.
yeah. Like,
All right, case number 4, 69-year-old female, history of RA, rheumatoid arthritis, subtalar joint and TN joint subluxation. So, kind of dystrophic, subchondral cystic changes on the CT scan. Uh, hard to tell on the AP and the oblique, but basically, is it medialized hindfoot? It's out of whack. It's out of position. So it's got an angular deformity in addition to the subchondral cystic changes within there. So again, is this, I'm trying to broaden it back for people when they look at these x-rays, like, what options do we have? Yeah, you can jump to the 3D printed, but, like, would a TTC nail just ultimately fail in your eyes with this situation? We talked about the femoral head allograft. Are there any other options that you would, what would you used to do before 3D printed for this case?
yeah, definitely would have been some sort of, Pan Taylor, because she's got quite a bit of deformity at the TN joint as well. So, and that's quite debilitating. Now, it's a rheumatoid patient. They're pretty used to having some pain, but, a Pan Taylor is definitely a limiting surgery. I think that would definitely be my concern, though, is that that talus going to hold any hardware, or by the time you're done trying to curette some of the cartilage off the top, you're going to go right through it because it's so cystic. I mean, you don't have all of them, but you scroll through all those CT scans, and it's just like just hole after hole after hole. So
Yeah, that looked like moth eaten, like it was a cancerous talus or something.
yeah, that was a terrible one for sure. Mhm.
Why don't you walk us through your approach here? Looks like another lateral approach fibular takedown. You're taking out the talus and most, if not all, the entire navicular. What's your approach here? What does it look like?
Yes, so going through that CT and going through with the engineers, the navicular was almost kind of fragmented a little bit, and so this was the funny shape that they came up for some sort of fusion. So you see, this is what we call sort of like gyroid kind of thing. So bone ingrowth into this entire thing. We don't have a joint surface, so this doesn't have to be cobalt chrome, um, and so. Yeah, so this, and then also had a incision over the TN joint. So dorsally, sort of over that TN joint, I typically stay there. So lateral approach for fibula, get the ankle, get the talus out, get things kind of reamed with the acetabular reamer through that way, and then get your implant in through that way, and then engineered it to have this one screw to kind of hold on to what was left of the navicular, which is kind of on that flatter kind of part of that implant there.
You talked about the acetabular reamer. So essentially, you're taking out the entire cartilaginous surface. So there's not really any prep that needs to be done. Historically, we would have needed to prep the cartilaginous surfaces before we put in a structural allograft, but you're just reaming through that in the shape of the allograft, or how are you judging how much bone to take?
Yeah. So when the engineers go through this, they will draw kind of they'll draw this ball and then they measure and they say, okay, this is based on a 36 millimeter, diameter. And so if that's what they seem to say, okay, well, that's kind of fits, then you have your acetabular reamers at, your hospital. If people are doing total hips, companies now even send, the reamers if you need, but you kind of know going into it that because they always give you a like a little sort of play by play. You're going to do this first. You're going to put this first, and then they give you the sizes, and they'll even tell you we think this screw size is going to be 70 millimeters. Like they're pretty accurate, really. I have had zero problems with any of my patient specific implants. I could tell you with like, oh boy, this doesn't fit. Oh, they screwed me. Oh, I've had no trouble whatsoever. But yes, so the reamer, and it seems kind of crazy, but it's obviously this like little half, circle thing, and you kind of angle up, you angle medial. I would take a picture here and there. Believe it or not, it will chew through relatively quickly. So I would not just kind of pull the trigger and go crazy. Like do a little bit, kind of take a look, do a little bit, take a look, and just make sure you're heading in the right direction. So, and then you kind of need to come down to calcaneus and make that, into a circle. And the nice thing about these circles is then you have kind of a couple different surfaces where you can kind of shift the heel a little bit, or, rotate things around a little bit. And then just one other thing I wanted to mention is, this has a screw to catch that piece of navicular. If you're going to put a screw, they cannot end in the implant. So the threads really can't end in the implant. So you have to engineer it in a way that, the screw is going through it, and then the threads obviously are in whatever you're trying to catch. You can't, come the other way, because then your threads are in an implant that's useless. So they always have to be engineered in a way that the threads are outside of it.
Brad's really into minimally invasive surgery. This is the opposite, Brad. This is
Yeah.
maximally invasive. This is big boy surgery.
Yeah. Well, I keep saying I'm not going to learn anything else, and that's on the list. But I don't know. We'll see.
There's two types of MIS: minimally invasive and maximally invasive.
That's right.
I do both of them, but
That's right.
it's all good.
Um, yeah. So talk a little bit about whether obviously this is one where we're doing a fusion. So spend a minute talking about the bony ingrowth. As you watch these heal, do you actually see bony ingrowth, or is it just so stable that you don't really care if there's bony ingrowth?
That's me. I don't care. So I think like most hardware, you're looking for lucency around, you're looking for things moving, shifting, maybe that if that screw breaks in the calcaneus from the rod moving. Um, I have not seen it. These things are so gritty that they hold on quite well in ingrowth. Now, I do know some people who have gotten CT scans after for academic purposes for sure, and you definitely can see it growing through. So this style is technically, much like wound vac stuff where there's like open and closed cells. So this is kind of like an open cell gyroid style where technically bone can keep going and keep going and keep going and actually go out the other side. So this is a style that can do that. Not all companies do that. And if you think of things like, okay, like a total ankle or something, that's like a closed cell, right? Because the bone's only going to grow into that little chunk and that's it. Because you got an implant on the other side. But this gyroid style, technically, you can follow those holes, can go all the way through. And so bone can go through. I have not done it often, but I do know some people. I know like Pete Highlander's done it for sure to look at some of his to see like, okay, what is this doing and is it healing? And so I've seen some of his CT scans. You can see some of that stuff growing through there for sure. The only other thing I would say is that for a lot of these implants, you have to use a straight nail because they generally have a hard time figuring out like where's this bend going to be. So I would say that there are some off the shelf styles like this now that's not true. You can use straight or bent. So that's the newest generation of things where, believe it or not, we all have a couple of shapes that we use quite a bit, and there are some companies now making off the shelf. I can get it tomorrow. I don't have to wait for 8 weeks, and so that's kind of the new, the potential new, uh, way that things are. Some of this is going to go.
Have you ever had either your like hospital or insurance deny this? Like you start the process and they say, "Wait a minute, I don't think this is indicated," or it's somewhat experimental, or "Hey, this
No,
patient's."
no, because the way that it falls with the FDA, there's nothing about like experimental or so there, you don't have a problem there. Where you do get a problem, obviously, it's cost, and they're expensive. As you have more people doing them, as you have more companies doing them, and now that we have some off the shelf styles, it's definitely a lot. It's helping for sure. But I've had once or twice where the hospital's like, "Wow, this is a little much." I would say most of the time, A, because you're doing a lot of other surgeries and they'll eat that cost a little bit. And B, the couple times that I've had people say something like, okay, well, if this is what's best for the patient, then we'll do it. But, yeah, there's definitely that can come up for sure. Smaller facilities, you're going to have a hard time. Bigger universities, sometimes it probably eats that cost a little bit easier, maybe. But never for like experimental. Did I ever have anything like, no.
As far as this one goes, obviously you have the intramedullary nail going through the 3D printed object device. Not all nails are created equal. So do you tell them ahead of time which nail you prefer to use and they build the implant around your TTC nail of choice?
Well, that's actually a very, very good uh, question because yes, they have every company's everything. So I would say for the nail, they're not generally as concerned, except for like diameter, but most of ours are 10, 11, 12. So they make like a 13 millimeter hole in there and it'll accommodate anything. But
Okay.
where it does come into play though, Jeff, is things like, okay, I'm going to do a constrained, talus. I want to use this company's screw. They will make the hole that fits that company's screw versus some other company's screw because all the heads are a little different. So, I want to, and using a headed Cancella 6.5 from this company. So they have all that information. But yes, you definitely, you tell them like, I'm going to use this company. And then they know everything from there. Because you can even match, like we've matched different total ankles with these. They know those companies. They have the tibial component and the poly kind of things, and they can make a talus match that.
Does it matter? I think it does. what metal the nail is made of. Obviously, you don't want any of the metal to metal interaction in there. So, how careful do you have to be with what metal the nail is made of versus what material the implant is made from? I'm sure they've thought of all that and they plan around that.
Well, I think from my experience, everybody forgets about it.
Not me.
Uh,
Here we go.
yeah, because it generally, from talking to some of the engineers, they feel like it's such a minimal reaction that it's not even worth like worrying, because now most of the time like this, titanium, okay, fine. But
Yeah.
I've, placed stainless steel screws through these. Like, this is a stainless steel screw 6.5 in a titanium custom implant. So uh, I can't say as I've seen anything crazy, and talking to them, because that's the first thing we've always been told, like, oh, don't touch this with that, and don't, you're going to
Mhm.
get a reaction. But they seem to think that maybe it's not. From my understanding, I haven't had anybody tell me that they're worried about it.
Good. One less thing to worry about. It's a good thing when you're dealing with these
I
complex
guess, yeah,
pieces. At least for my brain. Last case, we'll breeze through this. Then, if anyone has any questions, throw them into the Q&A section. We'll go a couple minutes long because we started a couple minutes after the hour to get our full hour. I do want to say thank you real quick before I forget to Pica for sponsoring this episode. And you will be I don't know, Rich will talk about the CME later. Let's talk about the case. Case number 5, 61-year-old female, history of bilateral total ankle arthroplasty. Failed, kind of a common theme here, subsiding to the talus, and just a big mess, kind of similar to whatever case it was
yeah,
earlier.
yeah.
Um,
Similar.
this one
I
has a
appreciate. I
yeah.
appreciate everybody doing them and getting into trouble, because it gives me something fun to play with. Then, so
So this one's a little different in terms of the bone ingrowth, but then also the shiny, polished joint surface. It's kind of a combo, which is a
yeah,
little different than the other one. So talk about this in terms of your construct and why you chose not to do anything at the TN joint in terms of trying to fuse that as well, like we did on the
yeah.
last one.
Well, so I think for her like sort of tailor neck head was not going to be as viable, and so it was all going to come out. I think the other thing, like everything, and so I think, Brad, you kind of brought up a little bit. Some of these fast track things are nice because, I mean, we're all doing things, and we all know that, like, okay, well, I wrote a textbook article, but by the time that thing came out 2 years later, I changed what I'm doing. And so I think what you see when you're talking to guys who are doing a bunch of these things is we've all kind of learned ourselves. We've learned from each other. I've learned a lot from talking to, some of our colleagues about some of these things. You're like, okay, that design, all right, well, let's change something. So for me, this one, the Taylor head neck was not going to really be viable. So I was going to need something to articulate. So that gives this boot style. Not generally a fan of doing that a lot if I can avoid it, but for her, we kind of had to. So that changed the material there. The other thing I do a lot now is I do this sort of a little bit more flat on the tibia. Using the Death Star or pill design, you have this, round thing, obviously, in that metaphyseal area of the tibia. And when you look at things like, okay, well, if this is going to subside, it's going to push right up into this soft metaphyseal bone. So I've shifted towards, I like my tibia cut flat, and then I have some cortical bone that's now sitting on this implant, versus having a round ball that's kind of up there. So it's just kind of as years, kind of go by, like, okay, I think I'm going to change this. I don't really like that style. And if I'm making it custom, I can kind of do either way. So that's why this was a little bit different.
Did have a question come in that says, any experience with PEC? Any other kind of for anyone just listening, it's kind of a super hard plastic compared to metallic. Any experience with PEC or different kind of materials and why we would choose metal over that?
I don't know. I guess, like everything, I guess that I have to look into it a little bit more. I have talked to some guys who have used it. I think, it's kind of like, okay, well, so that if you go back all the way back to that first case, you say, okay, well, if I had this AVN talus, whatever, and I can just put this talus to articulate. But the guys I've seen have done things like that. My problem with it is if you can't polish that to what we think a joint should be, like, what is that pec doing to an ankle, or what is that pec doing to a joint? It's not it's not as smooth. It can't be as smooth as like a cobalt thing. So I don't see how that can function as a joint. But there are people putting them in, and then they're like, okay, well then I buy some time or do something else. I don't know. I'm not sure. I haven't really done it a whole heck of a lot. I've talked to some people who have, but I don't know. I have to see where that's going to fit in my armamentarium, I guess.
So this question kind of talks about what I had just said there. So it says, how are you deciding whether to articulate your 3D printed talus with the TN and any difference in outcomes? Do you think that they retain any additional emotion that they can appreciate and function better? Do you think there's any better outcomes with retaining talonavicular joint function in these cases, or go ahead and fuse it because they're going to be stiff anyways?
I would say in a case like this one that's being shown, I would either I'd like to keep the neck and head and leave it. I think that works very well. For someone like this who couldn't, I would want it to articulate. Personally, for me, having a TN fusion as part of this, I don't think it's worked as well. I think that's a hard sell there. That's a little bit more of a shear problem that I think we can't fixate well. I've placed some staples, like I've put some holes in there to put some staples across. I put some screws across. I think that's a hard kind of fusion. Whereas like the sort of ankle part, the subtalar part, that axial load is much different and is more helping you than anything versus a TN that you're trying to fuse. So I would try not to incorporate a TN fusion if I could avoid it. I think it's not as good. Doing something like this where I keep articulation and or keep the head and neck.
The question says, any thoughts or concerns about using cobalt chromium aside from the weight? Some of the hip literature has shown associated encephalopathy with leaking. Any issues of metallic, not metal poisoning, but for the lay term, we'll call it that.
Well, yeah, I mean, there's definitely some people out there who suffered. It's kind of interesting, I guess, that it's still, this metal that's utilized whenever definitely been some metallosis kind of problems. I personally have not seen anything. I think it's also, obviously ours are much smaller. These joints are tiny compared to, a hip or something. I personally haven't had the issue with it. And since they still kind of use it and make it, I don't think there can be, as much of an issue. So I haven't, worried. But I would say most of mine are probably more in the fusion category versus having, something like this where there's a surface for a joint.
I think we'll start to wrap it up. Brad, do you have any other thoughts or questions there?
No, I mean, I think we kind of hit all the cases, and just to summarize, I think this was a kind of a good potpourri of different uses for these 3D implants, whether it's post-traumatic defects, avascular necrosis, some severe traumatic injuries, and I think it just gives us another option at some of these limb salvage attempts, other than kind of the like we talked about the bulk allograft, the nailing. And I'm really interested to see kind of where it goes because I don't know about you guys, but I have my own 3D printer that recently got here. Um,
Nice.
and got this a couple months ago, but I need to figure out how to use the programs on it to really start making some things. And so I just think there's a big opportunity with this 3D printing and customization with our patients, and hopefully it'll lead to better outcomes.
Brad, people do not want a talus that you printed in your office. I get it. You're trying to save some coin, but they do not want a talus that you made at home and brought into the OR.
Hey, it's not cobalt though, so there's no encephalopathy with this one.
Maybe
Yeah.
it's better. I don't know.
Yeah.
All right. Thank you, Dr. Burns, so much. If anyone's younger is listening, check out West Virginia University residency program. It's going to be a program on the rise. Thank you for joining us tonight. Thank you, Brad, for co-hosting. Thank you to Pica for sponsoring. Rich, take it away. Tell everyone about their CME.
Absolutely spectacular way to kick off second season. Great having you, Dr. Burns. Thank you to Brad and Jeff co-hosting this awesome series. We had a heck of a turnout tonight. What a way to start off the year. Just want to let everybody know we're over 1,100 registered on the Gatekeepers Journal Club. So that's pretty phenomenal. We're expecting that to rise over 2,000 at the end of this year. Another shout out to Pica for their support. But once again, thanks so much. What a great episode. Great night. Thank you so much, Dr. Burns. Have a
Yeah,
great night.
thank you guys.
Real quick, anyone who wants to follow Dr. Burns, check out WVU Pod Residency on Instagram. WVU Pod Residency on Instagram.
Disclaimer. Opinions expressed are those of the content creators and do not represent any employer or entity. The information shared is for informational purposes only and should not be construed as medical advice or used in any legal capacity, including establishing standards of care. All efforts have been made to comply with HIPAA regulations. No guarantees are made regarding the accuracy of statements or opinions provided. Interaction with the podcast does not establish a doctor-patient relationship. Please enjoy this podcast responsibly.